I would like to introduce Trevor Richens. He will present different cases of cateterization in children with cardiac.
Hi. I'm Trevor Richens. I'm an interventional cardiologist from the UK. Probably a lot less attractive than your lunch, which you're waiting for. So I'll go through this as painlessly as possible. I'm an interventional cardiologist, so I like talking about angiograms. I get very excited about the subject, but I'll try to gloss over anything too technical. I'm going to talk about some different circulations, and from it you can generalize to other circulations. We're going to talk about ASD and then arterial duct, which is really like BT shunts or central shunts. And then we're going to go through some single ventricle physiology. So we'll start off with the early systemic to pulmonary shunt, and then go through Glenn and Fontaine and how we assess pulmonary artery pressures in these patients. So I thought I'd start off familiar with an older patient. This is a patient I studied in October, Rosamond. She's 77 years old. She has a repaired ASD, atrial fibrillation, hypertension. And we noticed she still had a residual ASD, or it could be a stretch PFO. And as Olia showed in her previous talk, oops, wrong button. That was the hemodynamics a bit too early. Am I going the wrong way? I am, aren't I? No? So you're getting a preview of the talk. So as Olia, is it the red button for? As Olia showed in a previous talk, you can see she's got an enlarged right ventricle, flattened interventricular septum, and there's a gap in the atrial septum. So this was her diagnostic catheter results. So if we're doing a diagnostic catheter for pulmonary hypertension in adults, we do it under local anaesthetic and light sedation. In children, it's always under general anaesthetic. We use as little oxygen as possible so we don't ruin the results. So we normally keep it at 30% or less. She's in atrial fibrillation with a heart rate of 65, which means you have to take a long time averaging the pressures because they can vary from beat to beat. Make sure she's not anemic because that can change the results, that she's not hypocapnic, her CO2 is normal, and that she's not acidotic. And these were the results we got. So you can see that there's no real change in the saturations going through the heart. There's 78 in the pulmonary artery and 70 and 83 in the great veins, as you might expect. There's no significant desaturation in the lungs. The pulmonary vein saturations are 97. But she has evidence of pulmonary hypertension with a mean pulmonary artery pressure of 39 and a pulmonary vein pressure measured directly of 17. In congenital heart disease, we don't do that many wedge catheter measurements, Swan-Ganz measurements, because you can usually get through the atrial septum in most patients. So the first thing we normally do is a shunt calculation. What we mean by shunt is comparing how much blood's going through the lungs with how much blood's going through the body. And the way you do that is quite simple. You subtract the saturation in the aorta from the saturation in the systemic veins. Now, the purists would say that you do mixed venous saturation by taking 3 lots of the superior vena cava and 1 lot of the inferior vena cava. This measurement is very unreliable, and I think it can vary a lot depending on where you take it, because the blood coming back from the kidneys is full of oxygen, and depending on how much is coming back, that will change. So we tend to just take SVC saturation. So we take SVC saturation away from the aortic saturation and compare that with the saturation in the pulmonary veins, less the saturation in the pulmonary artery. And that ratio tells you how much blood is going through the lungs compared with the body. And here the ratio is 1.4 to 1. So she has a modest shunt through the atrial septal defect. We then would normally look at the pulmonary vascular resistance indexed. So this is the pulmonary vascular resistance for body surface area, and certainly in children it's extremely important you do that and correct it for body surface area. And the top bit of the equation, the pressure difference across the lungs, is very easy to measure. It's the mean pressure in the pulmonary artery less the mean pressure in the pulmonary veins. And that's also the transpulmonary gradient, which is another good measure of pulmonary hypertension. And hers is 22 millimeters of mercury, which is high. To measure the resistance, you also need to know the pulmonary blood flow. And this is really quite difficult in a lot of patients to measure. There are 4 ways of measuring pulmonary blood flow. The most accurate way is MRI, which most places don't have it. Only 2 units in the UK have it. I don't know whether anybody has it in Ukraine, but MRI measurement at the time of catheter is difficult. You can't really use thermodilution in right heart problems because you almost always have tricuspid or pulmonary regurgitation or a shunt which invalidates it. And so you're down to using either the Fick method or you're guessing. Now, there's a lot of information on this slide, but basically the Fick method relies on you knowing the oxygen consumption, how much oxygen a patient is using up. And that can be very difficult to measure. There are tables that predict it called the Lafarge tables, which I've referenced here, which use an equation. That measurement is extremely unreliable in children and not that reliable in adults. The alternative is that you can guess what the cardiac output is and correct it. So this is the calculation using the Lafarge measurement of oxygen uptake, and if you take a range, if you take the Lafarge measurement of oxygen consumption, then you end up with an indexed pulmonary vascular resistance of up at 5.1. If, on the other hand, you guess it based on the average cardiac output of a patient of this age, you get a range which encompasses that, and that's probably as accurate as anything else. There are lots of errors involved in measuring resistance, which is why I'm not a great fan of measuring how the pulmonary vascular resistance. You have to make sure the pressure transducers are zeroed. It's very easy to zero them wrong. That you take them in the more or less the same time. Simultaneous is best. Within 2 minutes is okay. And you have to take them at the same period of ventilation. I've already mentioned, so I'm going to have to take a drink. I've already mentioned that the Lafarge tables do have quite significant errors, and when you go down under 3 years of age, they're very big. Should we take into account dissolved oxygen? Will you keep the inhaled oxygen down around 30% or less so that you don't have to take that into account? When you go above it, you do have to start taking it into account. And then you've got to realise that saturation measurements vary a lot, that there's a big error in measuring the saturation. And so but when you use a measure that incorporates all of these parameters to generate it, then the errors are multiplied. And so there's a huge number of errors in measuring pulmonary vascular resistance. So when you're assessing pulmonary hypertension, pulmonary vascular resistance isn't the only thing you should measure. You also measure pulmonary artery pressure, transpulmonary gradient. And one thing that is useful in patients with primary pulmonary hypertension or patients with septated circulations is the resistance ratio. And that's because you then don't need to worry about cardiac output because it's the same for both sides. And so that's another useful way of measuring. I put my finger on the wrong button, don't I? And go way forward. Okay. So we go back to Rosamond. This is the patient. So what did she have? She had a pulmonary artery pressure of 39, so she clearly has pulmonary hypertension. She had a transpulmonary gradient of 22. She clearly had pulmonary hypertension. A resistance ratio of 0.6. And the PVRI is 5.1. Now, on some measurements, that is high. It's over 3, but it's under 6. And at our institution, we wouldn't worry too much about under 6. She's got a QPQS of 1.4 to 1. So she has got flow through her ASD. And the more interesting thing is she's got high pressures in the left atrium, and the end diastolic pressure in the left ventricle is elevated. So she's got post-capillary pulmonary hypertension. The ASD is a bystander. It's probably blowing off the left atrium and keeping the pressure down. So she has got pulmonary hypertension, but it's secondary to left heart disease. It's post-capillary pulmonary hypertension. You wouldn't close the ASD because it's probably helping her. And you wouldn't give her pulmonary vasodilators because you are probably going to give her pulmonary edema if you start her on pulmonary vasodilators. And so she needs treatment for her left heart. She needs to be on ACE inhibitors or beta blockers to reduce the left heart pressures. I think there's a big question whether she has some constriction left over from her ASD repair previously or a restricted cardiomyopathy, but we don't know that. So I'm going to move on to congenital heart disease now. So this is a child with a PDA, and trying to work out the shunt is now difficult. So trying to work out the shunt relies on you checking the pulmonary artery saturations and comparing those with the pulmonary vein saturations. But we've got two different pulmonary artery saturations. They're 92 in the left pulmonary artery and 72 in the right pulmonary artery. And that's because the PDA flow goes to the left and the PA flow goes to the right. So now it's extremely difficult to tell what the actual pulmonary artery saturation is. The problem is that there's streaming of flow to the individual pulmonary arteries, and the only way you can quantify the shunt is by knowing the individual branch flow, which is extremely difficult to do in the cath lab, if not impossible. You really need to do an MRI, or you can do it if you have the child intubated with a double lumen endotracheal tube, and you can measure individual oxygen uptake from both lungs, but that's really complicated. So because we can't measure the shunt, we can't measure the pulmonary vascular resistance index, and so we have to go on the other measures. The mean pulmonary artery pressure is 21. That's up a little bit if you take over 20, or it's borderline if you take between 20 and 21. So that's up a little bit. The transpulmonary gradient is also borderline. It's 6. It's right on the edge. So you have to look at other data. You have to use your clinical skills to decide whether there's a significant shunt through the duct. Is the child breathless? Is the left heart big? Is the left atrium volume loaded? Is the murmur loud? Is there a heave? And if you think that there's a significant shunt, or you could do an MRI and measure a significant shunt, then the PDA needs closing. If not, then the child probably has an element of early pulmonary hypertension from the duct and you would still close it. So this is Louis. He's 4 months old. He's 6 kilos. And this is a Sarno shunt. He has hyperplastic left heart syndrome and he has a Sarno shunt. Oh, good God. Fighting with this the whole time. Okay. He has a Sarno shunt going through from his right ventricle into his pulmonary artery. And this is the first stage correction of hyperplastic left heart syndrome. And he comes in to the cath lab to assess him before he goes for the second stage, which is a bidirectional Glenn. Now, checking what the QPQS is, what the shunt is in patients who've had an NORD operation, is a common question in the intensive care unit. You want to know if the child has enough pulmonary blood flow or whether they have too much pulmonary blood flow. And you only need 2 measurements to get that, and you can get those measurements from bedside monitoring. You can tell the SVC saturation from the central line, and you can get the arterial saturation from the arterial line. And with those 2 measurements, you can tell the QPQS. You make a few assumptions that the SVC is actually the mixed venous saturation. We've already talked about that. That's valid as long as there's no anomalous pulmonary vein. that the pulmonary vein saturations are 99% or thereabouts. Well, if there's no collapse on the chest x-ray, then the pulmonary vein saturations are going to be high, and that the aortic and the pulmonary artery saturations are the same. And that's certainly true in this situation. With that, just using those two measurements, you can do the calculation I taught you through before and tell that the QPQS is 1:1 and he's well balanced. And that calculation you do at the bedside frequently in intensive care after a normal operation or an early shunt. You then need to know whether he's got pulmonary hypertension. This child is going to go down a single ventricle pathway. It's going to be extremely important that the pulmonary artery pressures are normal. And so we measure the pulmonary artery pressure. Now, there's two ways of measuring the pulmonary artery pressure in these patients. One is to go down the shunt with the catheter, which you saw in the angiogram. The other is to go through the atrial septum up into the pulmonary vein and wedge the catheter in the pulmonary vein to check the pressures using a reverse wedge technique. In adult practice, you do Swan-Ganz catheters to measure the pulmonary vein pressure. Here, you wedge a catheter in the pulmonary vein to measure the pulmonary artery pressure. But there's problems with both. When you put a catheter up a big shunt, a shunt like that, you partly block the shunt and you drop the pressure. And in this case, the pressure measured going up the shunt was 8 millimeters of mercury. On the other hand, when you put a catheter into the pulmonary vein and you wedge it, you see a flattening of the trace and the pressure goes up, but you don't know if you're just obstructing the pulmonary vein or whether you've really wedged it. It can be very difficult to tell. What you can say is that the pulmonary artery pressure is somewhere between 8 and 13. So it's probably about right. So if the pulmonary artery pressure is between 8 and 13, it's low enough to proceed. Now, the reason it's so important to know the pulmonary artery pressures are low is that this child is going to go down a single ventricle pathway. A single ventricle pathway involves connecting the SVC up to the pulmonary artery as a first stage. And this is called a Glenn shunt. When a child has a Sarno shunt, the right ventricle is pumping blood to both the pulmonary artery and to the aorta. It's pumping to two different circulations, and it rapidly becomes volume overloaded. When you convert the child to a Glenn shunt, the ventricle is only now pumping to one circulation. It pumps blood round to the systemic circulation, then half of the blood, or thereabouts, comes back through the lungs into the heart, and the other half comes back from the IVC into the heart. So you've taken the volume load off the right ventricle to stop it dilating and failing early. So Glenn shunt's an extremely important step. But for it to work, it relies mainly on the child breathing. When the child breathes in, the lungs inflate, that pulls blood, sucks blood from the SVC into the lungs. And so it relies on there being very low resistance in the lungs, and therefore it's important that the pressure is below 15. So the criteria to proceed are usually that the pulmonary artery pressure is under 15, the transpulmonary gradient is under 5, or the resistance, if you want to measure it, is 3 or less. So in his case, is the pulmonary vascular resistance raised? Well, the QPQS is balanced, the mean pulmonary artery pressure is okay, the transpulmonary gradient is okay, and what you can certainly say is that a mean pressure of 13 is enough to push 90% of the cardiac output through the lungs. So he's going to tolerate a Glenn shunt. So he went on and had his Glenn. This is him 4 years later, and he comes back and his saturations are 72. 72 is a bit low for a Glenn circulation at 4 years. You'd expect it to be higher than that. So he comes to the cath lab and we're thinking, are we going to take him forward for the next stage? And these are the results. I'll try and press the right button this time. The arterial saturations are low, they're 74%. But so are the saturations in the pulmonary veins. The saturations in the pulmonary veins on the right side are 88, on the left side are 99, and average out about 91 within the left atrium. So the pulmonary vein saturations are reduced. You go through the calculations. The QPQS is more or less what you'd expect in this situation. The pulmonary blood flow is about 60% of the systemic blood flow. That's about right. But you've got very significant pulmonary vein saturation. And if you look at the mix of these two down to 91, it suggests that nearly 2.5 times the blood going through the left lung is going through the right lung. The right lung has a lot more pulmonary blood flow. Nevertheless, the transpulmonary gradient is low and the pulmonary artery pressure is low. And the reason that he's so desaturated is that he's got pulmonary arteriovenous malformations in the right lower lobe. And when you look at the contrast going through the lung, it's coming back much quicker to the right side than the left side. The contrast is whizzing through on the right side and then coming back late on through the left side. And about 30 to 40% of patients that have had his operation will develop a degree of collateral formation. The good news is that many of these collaterals, maybe 70%, will resolve when you complete the Fontan operation, and then the oxygenation will improve. And with the other parameters we've measured, we know that the total pulmonary vascular resistance is low. He'll tolerate a conversion to a Fontan, and the pressure of 10 to 11 is already good enough to oxygenate him, so he will tolerate the Fontan operation. So he can go ahead. Now, Sebastian is 8 years old. He has hypoplastic left heart syndrome. He came along age 8. We've been delaying his Fontan because we knew he had a left pulmonary artery stenosis. And he was struggling after the surgery. About a week after surgery, he was still in intensive care. He still had pleural effusion, suggesting there's a problem with the Fontan, and we took him to the cath lab. He had no fenestration. The Fontan pressures were high at 16. That's a bit high a week after a Fontan. You'd like them lower than that. But they dropped to 9 in the left pulmonary artery, and that's very significant. And the saturation showed that he had no shunt at all, that there was no increase in saturation on the pulmonary side, and no reduction in saturation into the systemic circulation. So this is his angiogram, or 2 of them. Press the right button. This is an injection into his inferior vena cava, and you can see that the contrast goes up through the extracardiac Fontan into the right pulmonary artery, and there's no fenestration flow. And now you see there's a very tight left pulmonary artery stenosis that we knew about, and the contrast is not really going through that left lung. So he's struggling. So the obvious thing to do would be to put a stent in the left pulmonary artery. When we measure his effective pulmonary vascular resistance, we can't now measure the pulmonary vascular resistance as a result of the precapillary arterioles, which is normally what you mean by pulmonary vascular resistance. You have to measure his entire pulmonary vascular resistance or total resistance to flow, which incorporates the left pulmonary artery obstruction. Now, at this age, you can use an assumed oxygen consumption, which has been published before. And this shows that for a Fontan that needs a PVRI of around 3, he's really high at 6.6. We'd like to stent the left pulmonary artery, but this is the problem. This is a CT scan reformatted. This is the Damus connection, so the pulmonary artery, neo-aorta and the aorta. This is the descending aorta. This is the left main bronchus, and this is the left pulmonary artery. So if we put a stent into the left pulmonary artery, we're going to compress the left main bronchus. And that's a major issue. That can lead to all sorts of problems, not just lung collapse, but you can get problems with erosion. So we're not keen on doing that. So he created a fenestration. So Bill was asking me about this the other day. A week out of a Fontan, it's still quite safe to take a long Brockenberg needle, push it through the wall of the extracardiac conduit, through the wall of the atrium, and then take a wire through and put a stent through to create a connection between the pulmonary artery and the atrium. And this is a covered stent, and it's actually potentially adjustable. So once it's in, you can make it bigger, or if you want to make it smaller, you can put a snare around it and shrink it in size, and because it's got a Gore-Tex covering it, it will actually go down and stay small. And this way of venting the right heart circulation is also a way of managing pulmonary hypertension more established, where you can put a stent between the pulmonary artery and the aorta called a pot shunt. So just to finish, this is an older algorithm than the one you saw earlier. This is one that came out in 2016, and I think people are generally becoming more conservative. I don't really understand why. This is an algorithm as to how you manage congenital heart patients with significant intracardiac and extracardiac shunts. And as you can see, it goes down. It doesn't rely on any one measurement for pulmonary artery pressure. It goes with the index pulmonary vascular resistance, but it also goes with the resistance ratio, which takes out the need for measuring oxygen consumption. And it has a safe zone, which is much higher than we talked about earlier, a grey zone, and then a high zone. And if you're in the grey zone or high zone, then you need to look at acute vasodilator testing. Now, vasodilator testing's been mentioned a couple of times. And traditionally, this was done with oxygen. When you use oxygen in patients with congenital heart disease, sure, it's a very good pulmonary vasodilator. It's also an excellent way of completely screwing up your shunt results. It will massively change the saturations. Quite often, you see the saturations in the IVC and the SVC shoot up, and it becomes almost impossible to calculate the shunt. Additionally, because you get a lot of dissolved oxygen, you have to make the calculation more complex with more errors in it. If, on the other hand, you can use another form of vasodilator, such as nitric oxide, it's a much more reliable test, or even nebulized iloprost is a more reliable test. If you have a completely septated circulation, so you have no intracardiac shunt, then you can use oxygen, because really what you're looking at then is whether there's a fall in the mean pulmonary artery pressure or a fall in the transpulmonary gradient. But when you already have a high flow situation, you can't use that. So we don't use oxygen for vasoreactive testing. We only use nitric oxide. But if you don't have that available, then the alternative would be to use iloprost. And there are published criteria for what constitutes a positive test. Now, there was a question earlier today from, I think, a patient representative about the risk of cardiac catheterization with pulmonary hypertension, and it's not insignificant. It is much higher than if you haven't got pulmonary hypertension, and certainly I've done catheters on patients with pulmonary hypertension and had problems. They're particularly prone to problems if you inject contrast in the lungs, so we tend to try and avoid putting contrast in. But about 6% of all catheters on patients with pulmonary hypertension will have significant problems in the first 24 hours. And that's defined mainly by pulmonary hypertensive crisis or pulmonary hemorrhage. And so it's not an investigation to be undertaken lightly. There's got to be a point to it. And although I do it frequently, you have to be asking a question and know you're able to answer it rather than just checking. So in summary, invasive assessment does carry risks, but it's often necessary. But it doesn't mean you shouldn't undertake very careful clinical assessment, which I think is still very important in these patients. You need to use all measure parameters and not rely on one. They all have different errors associated with them. And really, this is about getting an overall feel for the patient as much as getting one individual number. And if you find unexpected results, if something there you don't understand, then repeat the set of measurements, reassess it, and try and find the reason. Thank you.
So, Trevor, Based upon this talk that you gave, would you say that a couple things? One, a vasoreactive test for pulmonary hypertension has a significant element of art to it as well as science. Would you say that?
Yeah.
Yeah. Yeah. And so I bring that up because, we've seen a lot of these kids and we get some really interesting results in different parts of the world. The very first thing you listed, make sure your transducer is zeroed appropriately, is probably the most common mistake that we find when we make somebody repeat their test. Mm-hmm. Is that something that you see? I mean, you're obviously...
Yeah, I mean, I look at lots of tests that are sent to me, and people zero the way... Sorry. People zero the way they do with all cases, which is by taking the pressure line and holding it where they think the middle of the right atrium is. And we all do that. I've done it here. The correct way to measure, to zero a transducer, is putting a catheter into the left ventricle and zeroing it at the nadir. So you put it into the left ventricle and you move the line up and down until it zeroes at the bottom of that diastolic pressure. That's the correct way to do it.
You made a statement which I have harped on for a long time, and that is that you cannot take a single one of these measurements that we make and use it as a declaration of pulmonary hypertension. For instance, the pressure by itself, the QPQS by itself, the PVR certainly by itself. So we have tended to utilize the PVR-SVR ratio more than any other indicator if we're looking at a single thing. But truly, you need to look at all things, right?
Yeah, so I didn't show you, that first patient, the 77-year-old Rosamond, did have I did a nitric test. And she was getting uncomfortable when I was doing the nitric test, and her blood pressure shot up, but her PA pressure didn't. So her resistance ratio was incredibly unreliable when I did the nitric oxide test. So I think I've always gone with the resistance ratio, and I think it is really useful when you don't have a shunt. I struggle a bit when you have a shunt, because then you can't just compare like for like. You have to take into account the shunt.
So tell us all why the previous old gold standard of 100% oxygen for 10 or 15 minutes is no longer reliable for assessing pulmonary vascular reactivity.
I thought I did, but I'll say it again. It's reliable if you have a septated circulation. If you have no shunt, then you can use the resistance ratio, and the saturation measurements don't matter so much, because it's really just a ratio with the pressure differences. If you have to rely on the shunt, when you give oxygen, you can see the IVC and SVC saturations shoot up so high, you can't detect the shunt anymore. You have a lot of dissolved oxygen around. You have to start actually taking account of dissolved oxygen in every single measurement. And it just gets very difficult to work out anything using the saturations as the basis of the measurement. The pressure measurements are fine. But if you've got a VSD, the pressure measurement in the pulmonary artery is always going to be the same as the pressure measurement in the aorta. And so you can't use that as the assessment. It's the shunt that matters. If you've got an unrestricted VSD, you are looking at whether the QPQS goes up when you do the vasoreactive study, and that is screwed by giving oxygen. I would much rather give the child sildenafil for 2 days and then go and measure it. And if I put them into heart failure, I'll deal with it with diuretics rather than give them oxygen in the lab.
Чи у когось ще є запитання? I have one question. Is it reliable, for example, to close PDA and to measure pressures like to close with a balloon, temporary close, if you have some trouble with this.
It's as reliable as giving nitric oxide or iloprost. It's a temporary closure. We all do things acutely. It's an acute reactivity test. You do it for 10 minutes, 15 minutes, whatever, and then you see if it changes. It's not like real life, but it's as good as you can do. And I don't have, certainly temporary closing. If I'm going to close an ASD in a 70-year-old, I will always do a temporary occlusion to check the left ventricular pressure doesn't shoot up when I close it. And I think I've answered the question. But I only know I've answered the question if she feels better or he feels better in 2 weeks' time. These temporary things are the best you can do. And certainly you can temporarily close a PDA before you close it. But they aren't necessarily always correct.
Thank you.
So I have one last question about the results that you find from vasoactive testing in the cath lab. So you are taking a picture, a photograph of a moment in time. And this has always bothered me about this, because the physiology from the time that you make your vasoactive testing may be different from the physiology 2 hours later when the patient is awake.
Mm-hmm.
And so I think for us, this is one of the reasons why when we look at all these numbers, we say, well, is that photograph really indicative of the entire day for the child? And I don't know how to predict that.
Well, that's why you do double patches. If you relied on it, if you thought it was true, you wouldn't do double patches, because it would give you the answer. Oh, I answered that question with a question, didn't I?
Може, є ще запитання?